Hello, students. Let's talk about chapter 28, anti-Parkinson drugs. So just as a quick review, Parkinson's disease is that degenerative disorder, right? It's chronic, it continues to get worse, and it's caused by an imbalance of dopamine and acetylcholine in the central nervous system. So, quick hack to remember, too much acetylcholine, not enough dopamine. So people with Parkinson's disease don't have enough dopamine. So what do we have to do? We have to increase their dopamine levels, right? Why? Why is dopamine so important? Well, Parkinson's disease affects the messages that are sent from your central nervous system to your muscles, right? So your brain says to your arm, hey, pick up that coffee cup. But the person with Parkinson's has all of these transmission difficulties. And so when they pick up the coffee cup, they spill the coffee everywhere because they're tremoring, right? So the reason that they have those transmission difficulties is due to dopamine. So they don't have enough dopamine. They need dopamine in order to properly transmit signals. Decreased cells of the substantia nigra in the brain as well are going to cause the decreased dopamine and the increased acetylcholine. So if you want to know the root cause, that's what it is. But what is wrong? Decreased dopamine, right? And having the decreased dopamine and the increased acetylcholine are going to cause a bunch of different symptoms, okay? Having the increased acetylcholine levels can cause trembling, rigidity, difficulty walking, and balance problems. Also, bradykinesia. Bradykinesia is slow movement. Brady is slow. Kinesia is movement. So they're very, very slow as they walk, right? Getting these people up in the middle of the night is very difficult because they don't move to the bathroom. Those are called the cardinal signs of Parkinson's disease. Okay, the trembling, the bradykinesia, the balance problems, the rigidity, cardinal signs. We have other signs as well. And the group of signs we're going to talk about next are called extrapyramidal symptoms. Okay, and yes, they can be caused by Parkinson's disease, but they can also be caused by Parkinsonism. Parkinsonism is a cluster of symptoms that look like Parkinson's disease. Okay, so the tremors, the slowing of voluntary movements, muscular weakness can be called Parkinsonism. Other signs and symptoms of Parkinson's disease termed extrapyramidal symptoms are slurred speech, mask-like or emotionless face, difficulty chewing and difficulty swallowing called dysphagia, a rigid and forward bent posture, unsteady and shuffled gait, okay? And these are caused by the imbalance of dopamine and acetylcholine in Parkinson patients, but can also be caused by certain drugs, having a traumatic head injury, or a brain infection, which is called encephalitis. So we've talked about the problem. The problem is we have Parkinson's disease with increased acetylcholine and decreased dopamine. How are we going to fix the problem? Well, for Parkinson's disease, we're going to talk about 4 types of drugs that are possible fixes for this disease. The first drug class is called dopaminergic drugs. Technically, yes, these are dopamine agonists, but I don't want you to use that verbiage when you try to remember them because it's going to throw you off. Remember, dopaminergic, okay? These are going to increase dopamine, and we're going to talk about how in just a second. So dopaminergic drugs include amantadine, bromocriptine, carbidopa, levodopa, and carbidopa-levodopa. Now, when we're talking about carbidopa-levodopa, I want you to recognize it as a together drug. Levodopa can be given by itself. It is converted into dopamine in the body, which is good because dopamine itself doesn't get through the blood-brain barrier, but levodopa has a higher success rate of getting into the brain. However, levodopa is the active ingredient. It is what turns into dopamine. And we know that if we give our client dopamine, we're going to be increasing their heart rate. We're going to be increasing their respiratory drive. We're going to be increasing their blood pressure, right? All of those things on that sympathetic side, the adrenergic side, the anticholinergic side, right? But we don't want all of those effects all over the body, especially like we don't need all of the hard effects of dopamine. We don't need all of the additional effects of dopamine. We just want the brain effects. We want to have increased dopamine in the brain, right? So we don't have all these crazy symptoms. So anyway, we give carbidopa with the levodopa. Carbidopa by itself does nothing. Carbidopa by itself does nothing. It is not an active drug in the carbidopa levodopa concoction, right? Carbidopa, however, keeps the effects of dopamine inside that brain and doesn't allow those systemic effects to occur. So we give it in this combination drug known as carbidopa levodopa. We get the best benefits without any of the cons, right? Any of the negatives. We also can give amantadine or the bromocriptine to make dopamine more available. And then also MAOI dopaminergics. MAOIs, we're going back to antidepressants, right? So these are also in the therapeutic class of antidepressant medications. MAOIs are monoamine oxidase inhibitors, right? Monoamine oxidase inhibitors. MAOIs, rasagiline and selegiline, actually make dopamine more available in the brain as well. If you remember, MAOIs increase serotonin, norepinephrine, epinephrine, and dopamine. They work on all four neurotransmitters. So if they increase dopamine, they're going to be a dopaminergic drug. And these two particular ones are used within Parkinson's disease. Okay, so uses, we just said that Parkinson's disease, right? But also Parkinson-like symptoms. So if your client has extrapyramidal effects, maybe because they had that injury or they're on a drug that's causing them, or encephalitis perchance, right? Or they have restless leg syndrome. Amantadine can be given for viral infections as well. Fun fact. Amantadine, it interrupts the synthesis of RNA and DNA, and therefore can be given to slow down viral replication, which is great. I want you guys to take some time and look at the drugs that could cause Parkinsonism, okay, or the extrapyramidal effects, right? I want you to look at some of those drugs that can elicit that type of response, that type of adverse effect. Okay, adverse effects for dopaminergic drugs all by themselves, things that increase dopamine. Well, if we're increasing dopamine, we're probably going to end up on that sympathetic side, right? So on that sympathetic side, we sometimes see some of the GI symptoms slip through. So things like dry mouth, because it's anticholinergic side, right? Dysphagia, difficulty swallowing, anorexia, lots of appetite, nausea, vomiting, abdominal pain, constipation. We also could see increased hand tremor, headache, and dizziness, and these really specific symptoms known as, I am so sorry, my puppy is going crazy today, known as coriform movements. Coriform movements are involuntary muscular twitches that occur in the limbs or the facial muscles. Okay, they occur in the limbs or facial muscles. Twitches of these muscles. Coriform movements. And then also dystonic movements or dystonic movements, they are muscular spasms, and they're really limited to the tongue, the jaw, the eyes, and the neck. And we start to see those spasms in people that have too much dopamine on board, okay? So similar to a lot of our antipsychotics potentially causing things like tardive dyskinesia because of increased dopamine levels, if you have too much dopamine on board, your client may end up developing these dystonic movements. Other adverse effects of these medications, dopaminergics, include dementia, depression, psychotic episodes, paranoia. I mean, that really makes sense, right? Because we know the people who are psychotic and have true psychosis have increased levels of dopamine. So if they have increased levels of dopamine, and that's what's causing them to be psychotic, if we give somebody a dopaminergic drug, we raise up their dopamine, it would follow that they then may have some psychotic episodes or paranoia if they have too much dopamine. And then suicidal tendencies as well. We know that dopaminergic drugs have an increased tendency to cause malignant melanoma. So just keep an eye on your patient's skin. Be looking for irregular borders, dark black, dark brown, right? Places on their skin, things like that. Contraindications. Who shouldn't have a dopaminergic drug? Well, a client that's allergic to the drug should not have the drug. Additionally, levodopa by itself should not be given to anyone with glaucoma or a person on MAOIs. Why? Well, levodopa, we talked about, turns into dopamine, which raises pressure, right? We know that MAOIs already have a risk of increasing pressure, all right? Extreme hypertension because they affect dopamine. And then glaucoma is increased intraocular pressure. So if we give levodopa to someone with glaucoma or who's already on an MAOI, we may really, really worsen their glaucoma by increasing their intraocular pressure, or put them into a hypertensive crisis because they're on the MAOI. We want to be careful giving dopaminergic drugs to anyone with cardiovascular or pulmonary diseases, anybody who has peptic ulcer disease, anybody with kidney or liver issues, anybody who's psychotic, pregnant, or lactating. Interactions of dopaminergic drugs. There are 5 primary interactions. The first interaction is with selegiline and rasegiline, or MAOIs. If we give those with meperidine, which is Demerol, right, we can see an anti-metabolite conversion. Why is that important? Well, anti-metabolite conversions result in impaired or interfered with DNA and RNA synthesis. So we're going to end up with the inability to replicate cells, which can be a really serious problem when we talk about like the immune system and the ability to heal our body and the ability to produce red blood cells, right? So we don't want that. We don't want that effect. So we avoid Demerol when we're on those MAOIs. Tricyclic antidepressants actually increase the risk of hypertension and dyskinesia. So we want to stay away from tricyclic antidepressants while on dopaminergic drugs. Antacids increase the effect of levodopa. So just be aware of that, be cognizant. Anti-epileptic medications, so seizure disorder drugs, right, are going to decrease the effect of levodopa, right? Because we're trying to decrease the central nervous system conduction, transmission, right? Because it's over transmitting. So it would make sense that these are working in like almost an opposite effect from one another. And then foods high in B6, pyridoxine, right? They actually are going to decrease the effect of levodopa. So think about that for a second. Can you think of some foods that are high in B6? I'll give you just a second. Okay, B6. We talked about these in class, right? Bananas, green leafies, some meats like beef, right? Some porks, sweet potatoes, those kind of things. Lots and lots of things have lots of B6. Organ meats, fish have a lot of B6, a lot of fruit, but not citrus fruit, have a lot of B6. Okay. So educating your patient on that, that's going to be a big thing. Okay. The next class of drugs we're going to talk about. So we talked about dopaminergic drugs for people with Parkinson's. Let's talk about dopamine receptor agonist drugs. Dopamine receptor agonist drugs. So these are actually going to act on the postsynaptic dopamine receptors in your nerve cells and mimic dopamine. They're going to act like dopamine. Apomorphine, pramipexole, and ropinirole, Requip, right? These are your dopamine mimickers. They get in that receptor site, they act like dopamine, and the body gets the effect of having dopamine on those receptors. Used for Parkinson's disease, restless leg syndrome, and then apomorphine is actually used for the on-off phenomena of Parkinson's disease. And that's when you've been treating your client maybe with like carbidopa, levodopa, and it was working great, and then it stops working, and we start seeing those Parkinson's symptoms reemerge. We might give our client apomorphine because now they have the return of those Parkinson's symptoms. You have to give apomorphine with an antiemetic. It can cause extreme nausea and vomiting. Adverse effects of dopamine receptor agonists. They can cause nausea, vomiting, dizziness, somnolence, potentially hallucinations, confusion, visual disturbances, postural hypotension, abnormal involuntary movements, or headache. Don't give them to someone who's allergic to them, and be careful when giving to patients with dyskinesia already, orthostatic hypotension already because of the risk of hypotension, hepatic or renal impairment due to metabolism and excretion, cardiovascular disease, history of hallucinations or psychosis, and pregnancy. Interactions. Well, we don't want to give these with other CNS depressants because there may be an increased risk of central nervous system depression. We also don't want to give these with levodopa because when we give a receptor agonist or a dopamine receptor agonist with levodopa, we can put us at increased risk for all of the shared symptoms, right? And one of the big ones is hallucination. So we don't want our patient to start becoming paranoid and hallucinating by giving them both together. Ciprofloxacin increases the effect of dopamine, the dopamine receptor agonist, and cimetidine, verapamil, quinidine, and estrogen also do. Phenothiazines actually decrease. So I apologize that that's not correct on the slide. They actually decrease the effect of the dopamine agonist. Okay, the third, okay, let's briefly rehash that. Dopamine receptor agonists mimic dopamine. They act like dopamine at the receptor site. They're really good for on-off phenomena and can be a good option for your client that's no longer responding to your typical dopaminergic drug, okay? COMT inhibitors. So there's this enzyme that breaks down or eliminates dopamine. It's called catechol-O-methyltransferase, COMT. Okay, you don't need to know that. Catechol-O-methyltransferase, don't stress about that. Just know them as COMT inhibitors. COMT is that enzyme that eliminates dopamine when given with levodopa. So these are given with levodopa or carbidopa-levodopa, right? The COMT inhibitors increase the plasma concentrations and how long the levodopa works. So these are good to enhance the effects of like a carbidopa-levodopa or levodopa. The two COMT inhibitors I want you to know, entacapone and tolcapone, Comtane and Tasmar. Okay, these are really just used for Parkinson's disease. Adverse effects of these medications: dizziness, dyskinesia, hyperkinesia, akathisia, which is extreme restlessness and increased motor activity. Also, we might see some GI stuff like nausea, anorexia, diarrhea. We might see some orthostatic hypotension, sleep disorders, excessive dreaming, somnolence, muscle cramps. The big one for these, specifically tolcapone, is liver issues. These can cause liver dysfunction and even failure, COMT inhibitors. So we want to be constantly monitoring our patients' liver enzymes, right, to see how their liver is doing. Additionally, we would not give these medications, specifically tolcapone, to anybody with a liver dysfunction. We don't want to give COMT inhibitors to anyone who's allergic. And we also stay away from pregnancy or lactation. Want to be careful giving these to anybody who already have high blood pressure or low blood pressure or have decreased renal or hepatic function due to the ability to metabolize and excrete these. Interactions. We don't mix COMT inhibitors with MAOIs because it can increase the risk of toxicity of both of the drugs. So COMTs can become toxic levels and MAOIs can come at toxic levels. And then we don't want to mix COMT inhibitors with adrenergic drugs due to increased risk of cardiac symptoms. So we start to see that increased hypertension, increased risk for tachycardia, increased risk for everything else that goes with the adrenergic side of the nervous system, right? COMT inhibitors, they block the enzyme that gets rid of dopamine, right? They block the enzyme that gets rid of dopamine. They also help levodopa work better. Okay, but be careful, they cause liver issues. That's the big thing on those. Cholinergic blocking drugs. So this is our last class. And we've actually already learned about these drugs under a different category, different therapeutic class, right? Cholinergic blocking drugs, also known as anticholinergics, are used for Parkinson's disease. Benztropine, diphenhydramine or Benadryl, and trihexyphenidyl are used for Parkinson's disease. They're also used for Parkinson-like symptoms like Parkinsonisms, right? Drug-induced extrapyramidal disorders, specifically when you're taking like antidepressants, antiemetics, first-gen antipsychotics, lithium stimulants, right? All of those can cause extrapyramidal disorders, all of those signs and symptoms, extrapyramidal symptoms. These drugs work by blocking acetylcholine, which helps the dopamine to transmit better. Okay, transmit better. So dopaminergic drugs increase dopamine. Dopamine receptor agonists mimic dopamine. COMT inhibitors block the enzyme that breaks down dopamine, and cholinergic blocking drugs block acetylcholine to enhance dopamine transmission. Now, anticholinergics are less effective than your dopaminergic drugs like levodopa, right? But they do have less adverse effects. There are decreased adverse effects with cholinergic blocking drugs for Parkinson's patients. So if you have a client that's really struggling with the symptoms of the more intense meds, this might be a better choice for them. Adverse effects. Well, these are anticholinergics. So they're working on the anticholinergic side, right? The adrenergic side. So what might we see? We might see dry mouth, blurred vision, dizziness, nausea. We might also see some nervousness, rash, hives, urinary retention, because these are drying us up, right? Dysuria, difficulty or painful urination, tachycardia, working on the adrenergic side, muscle weakness, disorientation, and confusion. Good news is most of the adverse effects of anticholinergics get less pronounced with time. So they're not as bad over time once the client gets used to the medication. Who should not have an anticholinergic? Well, anyone who's allergic, has glaucoma, has an obstruction in their intestines, right? Like a pyloric or duodenal obstruction, peptic ulcers. They have a problem with urinary retention already, like prostatic hypertrophy. They have an issue with peristalsis of the esophagus, known as achalasia. It's a failure of the muscles in the lower esophagus to really relax, which causes dysphagia, right? And dysphagia is a symptom of an adverse effect of anticholinergia sometimes, or anticholinergics sometimes. So we want to be careful giving it to somebody who already has it. In fact, we don't want to give it to someone who has the condition known as achalasia. Myasthenia gravis, because they have issues with acetylcholine, right? They have issues with acetylcholine. So we don't want to give them a medication that's going to work to decrease acetylcholine and increase their dopamine levels. And then megacolon. Precautions. Careful with people who have cardiac things, right? So tachycardia, arrhythmia, high or low blood pressure. They already have some urinary retention. They have decreased liver or kidney function, obstructive disease of the urinary GI tract, or they're the elderly. Okay, we want to be careful in the elderly. They're more prone to the dehydration, the dysphagia, all of those kind of symptoms, right, of the anticholinergics. We do not want to give an anticholinergic med with amantadine. It's actually going to increase the anticholinergic effects. So you're going to see those adverse effects worsen. Digoxin increases digoxin serum levels. We can cause digoxin toxicity. Haloperidol, because haloperidol is an antipsychotic, it's not going to work as effectively when given with a medication that's going to increase the level of dopamine. So you're going to have potentially some psychotic behavior. We don't want that for a client on haloperidol. So don't mix the two. And then phenothiazines is going to increase the effects, those anticholinergic effects or dry you up effects. Okay. So just as a quick refresher, anticholinergic drugs or cholinergic blocking drugs, benztropine, diphenhydramine, trihexyphenidyl, work for Parkinson's disease, Parkinsonism, extrapyramidal disorders, and they cause lots of the dry you up effects. How do they work? They enhance dopamine transmission. I apologize. Okay, nursing process with these anti-Parkinson drugs. Assessment. Well, you need to get a good baseline history, right? You need to do a thorough exam of your patient, especially neuro. And if you have a client that's really like cognitively impaired or struggling in this area, and their ability to communicate, maybe you need to get the family members to help you. You need to document the symptoms in detail, and you need to ask good questions about how this is impacting their everyday life and their ability to do things for themselves. You need to ask them about and assess for depression, right? We want to see how their psychiatric state is. We also need to do a focused neuromuscular exam, which differs from neurological. Neuromuscular is looking at how their brain transmits signals to their body and how their body responds. Okay. Check the baseline hepatic function, especially before giving something like tolcapone, because we can have serious issues with the liver. You need to continue to check those liver labs, right? Continue to check those liver labs because there's a risk for hepatic injury. We also need to watch for nausea, jaundice, and right upper quadrant tenderness, which would indicate issues with the liver. Continue to reassess the client, compare your data back to baseline to see if we've made any improvements by adding the anti-Parkinson drug. Diagnoses, the RN may diagnose the client with imbalanced nutrition, less than body requirements because of the nausea, dry mouth, constipation due to neurologic changes in the bowel, and also the dry you up effects of some of these medications. Risk for injury related to the dizziness or lightheadedness your client may experience, the orthostatic hypotension and loss of balance that kind of either come from the drugs or from the condition itself. Impaired physical mobility due to balance issues, unsteady gait, and dizziness. Disturbed sleep pattern related to the involuntary movement at rest, especially if it's like restless leg, right? Like that's what we're talking about there. They're not able to get good sleep. Planning, what do we want to see? We want to see the drug work the way we want it to, an optimal response to drug therapy. We also want to support the patient's needs related to managing their adverse reactions. So if they have one, we want to manage it, and then we also would like to prevent it, right? Or mitigate adverse reactions. We don't want our patient to fall or get hurt. So absence of injury is definitely a goal for us. And we want our client to understand and comply with our plan, right? Implementation. I'm giving an anti-Parkinson drug. What should I do? Hold that dose, especially if sudden behavior changes kind of pop up. The client starts to have hallucinations. They get delirious. They're just really out of sorts. Tell the doctor. Hold the dose. Tell the doctor. Also, you need to teach your patient or their family to journal, to be writing about this behavior, possible adverse effects that have popped up. So that way they have something to refer back to when they're talking to the physician. Be aware that these drugs can cause weight loss. So as the nurse, you should carefully be watching your client's weight. And then providing some dry mouth comfort interventions, because dry mouth is a very common symptom with this. We know dry mouth can cause dysphagia. So we want to definitely be giving them like sips and chips or some oral care, or having them, if it's appropriate for that client, have them stuck on a lozenge or a hard candy or something like that. We want to promote a nice, calm environment, be serving small, frequent meals due to the, the decreased appetite, but also potentially some nausea and vomiting. Take the drug with food if there is GI issues. Watch for signs and symptoms of constipation. Really, especially in our elderly, right? Because they're really prone for constipation and dehydration. So keep an eyeball on your patient. Obviously, with that, we're talking eyes and nose, right? Increase fiber in the diet, increase water. If there's stool softeners ordered, give those for the constipation and as a preventative, right? Provide assistive devices as needed. So if your client needs a walker or cane because of their lack of balance, get them hooked up. Monitor for hallucinations, especially in your older clients. Use fall risk precautions. So whether that's, obviously bed in lowest position, collar and reach, non-skid socks, assistive devices, but it might also be a bed alarm or bed rails or whatever we need to do. Orthostatic hypotension precautions. And then if your patient has restless leg syndrome, you might want to help them get to sleep, right? Because as restless legs symptoms can keep our patients up. Maybe a hot bath before bed, a relaxing activity like a maze or a crossword puzzle or word search or something like that. And then a nice leg massage. Let me tell you, a leg massage goes the extra mile, right? Giving your patient the leg massage is really nice. No throw rugs, encourage the use of handrails, no obstacles, right? No like electric cords around the place, because they're going to have an increased risk of fall with those things in the way. And we definitely don't want these clients driving or drinking while on these medications. No driving, no drinking. Potentially driving later after we know how this medication would affect them, but it has to be with the doctor approval. And then our client definitely needs to follow up. So keeping those follow-up appointments, teaching your client to keep those follow-up appointments, and then also teaching them about that vitamin B6 precautions, bananas, other fruits, except for citrus fruits, organ meats, green leafy, starchy vegetables, those kind of things. Okay. Evaluation. How do we know that our client's care plan was successful? Well, we got whatever effect we wanted, right? We decreased our Parkinson symptoms or our extrapyramidal symptoms or the restless leg syndrome symptoms, right? Whatever we wanted to do, we did. Also, we mitigated, which means we prevented or we managed adverse reactions. No injury. The client didn't fall, they didn't get hurt. Your patient verbalizes an understanding of treatment modalities. They understood and they complied, right? They understood and they complied. Is the following statement true or false? Parkinson's disease is a progressive neurologic disease caused by an increase in dopamine in the brain. That's not true. Parkinson is related to decreased dopamine in the brain. Yes, it's progressive. Yes, it's neurologic. And yes, it's affecting dopamine, but it's decreased dopamine is the issue. Cardinal signs of Parkinson's: tremors, rigidity, bradykinesia, right? When drugs or other illnesses cause Parkinson-like symptoms, these are termed Parkinsonism or extrapyramidal symptoms. Well, that's true, right? Extrapyramidal symptoms or Parkinson-like symptoms, Parkinsonism. The drugs used to treat Parkinson's disease and Parkinsonism either supplement dopamine or block excess acetylcholine to enhance neurotransmission. Yes. So the issue is we have interruptions in neurotransmission because of decreased dopamine, increased acetylcholine. So we want to supplement the dopamine, block the acetylcholine, so we have better neurotransmission. Okay, guys, that's it. I apologize for the puppy dog this morning. Hopefully she's calmed down a little bit and we can move on into chapter 29 and 30.